You're listening to the ATS Breathe Easy podcast, brought to you by the American Thoracic Society.
Hello and welcome. You're listening to ATS Breathe Easy with me, your host, Dr. Amy Attaway. Each Tuesday of every month, the ATS will welcome guests who will share the latest in pulmonary critical care and sleep medicine. Whether you're a patient advocate, or healthcare professional, the ATS Breathe Easy podcast is here for you. Joining me today are two people who have strong ties to the American Thoracic Society, Dr. Monica Kraft and Dr. Gardner. Dr. Kraft is a former president of the American Thoracic Society and the Marie M. Rosenberg Professor and System Chair, Department of Medicine at the Icahn School of Medicine at Mount Sinai. Dr. Gardner is Chief Research Officer of the Asthma and Allergy Network and a member of the Public Advisory Roundtable, which integrates the patient perspective into ATS programs and activities like today's podcast. Welcome to you both. So for this episode, we wanted to focus on an issue that a lot of clinicians deal with, which is dealing with asthma and then biologics in the context of treating asthma. Dr. Monica Kraft is an expert on many things, and we are so fortunate that she's going to spend her time and expertise discussing this podcast, which is going to be on asthma and biologics. So Dr. Kraft, again, we are so excited to have your expertise today. And I think one of the things we wanted to start with was maybe you could talk about what is a biologic.
Well, thank you. Thank you so much, Amy, and the ATS for having me today. It's exciting. You know, I love the ATS, special place in my heart. And so, of course, talking about asthma is another topic I know very well. And, you know, biologics have been a very exciting aspect to asthma care. So I'm really excited that we get to talk about them today. And a biologic is really something that comes from a living thing, like a bacteria, a plant, a cell, and it targets a certain receptor or pathway of inflammation. In this case, it's the lung. You might have heard of Humira for rheumatoid arthritis and etanercept. Those are biologics for other diseases. We happen to have 6 biologics to treat asthma because the understanding of the immunology of asthma has exploded over the last couple of decades. And that has allowed the development of these treatments that target these specific receptors on cells and pathways. And we have them in our armamentarium now to treat our patients with severe asthma. So I'm really happy about that.
Yes, I would say it has really revolutionized, biologics have revolutionized how we treat asthma. And so I think, as you mentioned, there's 6 different ones. So we wanted to really get your perspective on what factors guide your selection of a specific biologic for a particular patient for their asthma.
Sure, absolutely. So I take care of patients with asthma across the spectrum, as well as COPD and other lung diseases. But when it comes to severe asthma, I start thinking about a biologic when I'm seeing a patient who is already really maximized with inhaler therapy. So they're on very good inhalers, an inhaled steroid, and a long-acting beta agonist or a long-acting albuterol. And usually it's in one device, and they're using that, and they're very adherent. They may be on a second inhaler, which is like a tiotropium, something like that. That's a long-acting muscarinic antagonist. That's also a bronchodilator, or it could be a controller like montelukast, something else. So they're usually on at least 3 controllers. And I've had conversations with patients who have been adherent. They know how to use these medications. And they're still having trouble with asthma, mainly asthma attacks, meaning attacks that result in very acute onset, shortness of breath, wheeze, cough, require emergency room visits, urgent care, sometimes hospitalizations, and ultimately oral or IV steroids. So those are really concerning events. And so when patients experience those, and I would say, you know, twice a year for sure, but even once a year, in my opinion, is not ideal. But twice a year, yes. And in some countries, it takes actually 4 times a year to qualify for a biologic. But in the U.S., we start thinking about it maybe once or twice a year. Then that's one of the features. We also want to make sure that additional processes that are going on with them have been addressed that can actually add to medication burden in asthma, like allergic rhinitis. Are they taking care of their sinuses in terms of if they have an allergic component to their asthma? Are they using nasal steroids, things like that to really help with the rhinitis? Do they have heartburn, gastroesophageal reflux disease? We know that just having acid in the esophagus can trigger a nerve that causes the airways to constrict. So we definitely want to take GERD or reflux off the table. So is that being treated appropriately? Do they need a gastrointestinal GI evaluation? Do they have obstructive sleep apnea? It's another process that can actually add to medication burden by increasing vagal tone. That same nerve that causes airway constriction with heartburn can also be triggered in sleep apnea. And then the last issue is the upper airway. With all this rhinitis happening, sometimes the upper airway, it functions abnormally and can cause wheezing and shortness of breath and symptoms that really aren't asthma. So you have to make sure that's not going on. And not to mention, you've ruled out other diagnoses. So you're sure that's the diagnosis. You've really maximized their treatment. You've addressed these comorbidities, and yet these patients are still having these asthma attacks. At that point, I'd start thinking about a biologic. And then, of course, the whole biomarker piece comes in. And if you'd like me to go into that, I can, or we can just stop here and that'll be a start.
Yeah, well, I think it's we were thinking to talk about the biomarkers, like how that kind of guides you, and then actually thinking about the patient perspective, right, from DD.
Exactly.
Right.
So you've got this patient in front of you with severe asthma, has all the characteristics I was letting you know about, and then we want to figure out what kind of asthma they have, because it's not a one size fits all. It's very heterogeneous, and there's certain kinds of asthma that respond well to biologics and some that don't. And the 5 out of the 6 are really focused on this type 2 asthma associated with the eosinophil. So the eosinophil is a white cell that you can measure in the blood, it's in the lungs, it's in the sinuses. That's associated with sometimes allergic inflammation, sometimes non-allergic, but it's this type 2 inflammation. And with type 2 comes these certain proteins that these cells make. You might have heard of interleukin 4, interleukin 5, interleukin 13, sort of our 3 favorites. So we look at the blood eosinophil count for sure, and if that's elevated, really above about 150, but certainly above 300, we really start taking notice. And then, if possible, try to measure nitric oxide in the exhaled breath. Call that FeNO. That's also a measure of untreated type 2 inflammation. So if we see the eosinophils up and the FeNO up, or at least one of them, we start thinking, okay, this patient has type 2 inflammation that's persists despite maximal therapy. And then we start thinking that maybe we have biologics that really target these type 2 pathways, which is really gratifying to be able to offer that. And then the last piece I'll say is these are injectable medications, and they're very expensive. So we go through a whole prior authorization process, which we can talk some more detail about. But then it's also really shared decision-making with the patient, because nowadays they're all for home use. So patients are injecting themselves after teaching. We teach them in the clinic. Now, I have a few patients that are a little bit nervous about doing that, so they actually go to infusion centers and get their injections, or they come to see us in the clinic. I'd say the majority are learn to inject themselves and feel comfortable with it. But that's a very new aspect to asthma treatment that we really hadn't really addressed. And I will say, at least, a lot of patients embrace it. Some are a little nervous about it. So that also goes into the conversation about whether they're willing to do this. And so then we talk about how long they're going to be on it, which is at least 4 to 6 months, to make sure that it's working. It really takes that long to decide if a biologic is benefiting a patient and if they're ready to take on that challenge. And so that's where we stop with that. And then Dee Dee, I'd love to hear your thoughts from the patient perspective, if I've missed anything, if there's anything more you want to cover.
Yeah, so just in regards to shared decision making, I think that it's important that patients have an idea of what that means. Many of our patients here with the Allergy Asthma Network, when we use that terminology, they think they know, but maybe they don't. And so it gives us an opportunity to provide maybe role modeling or even a video to talk them through, or even a handout that maybe they can answer some questions before they come to meet you. So then they're prepared for that shared decision-making process, and that they feel empowered to be a part of the process to then determine if biologics are the right answer for them and their treatment for their severe asthma.
And I think some of it we had discussed that it has to do with like how often you can give the medication, how that works is conducive to their lifestyle. I think that was one of the things as well, right?
Right. And the biologics, they're variable in terms of how often they need to be given depending on the biologic. There's one that we give every 2 weeks. There's others that are every 4, and one that's every 8. And they're mostly the injection, the sub-Q injection. There's one that's in IV form that we tend to use less often. That does require an infusion center, and it's a weight-based type of dosing. I have used it, especially for patients where there's like obesity is a factor, and you want to make sure and really dose ideally. I have used it in those cases, but the vast majority of the time we're using the injectable. And so that has to be something very, acceptable to the patient. Oftentimes the medication gets mailed to their home once they have a teaching session and are interested in taking it at home, and then they take it themselves. But the duration or the frequency is actually really important. Some people aren't as interested in every 2 weeks, but are willing to maybe try every 8 weeks. And now I'm happy to say there was a recent New England Journal paper suggesting we may have an inhibitor of interleukin-5 coming out that's every 6 months. So that's exciting to think about. You almost have to put that on your calendar to remember to take it.
That is so exciting. Oh, go ahead, Dee Dee.
I was going to say that'll be better for patients who have a little bit of needle phobia, if you will, because we've done a number of focus groups with patients and when it comes to utilizing biologics. And so their perceptions sometimes are that, there is a fear of needle. But like you said, once we get through the education, then patients are willing to accept that. You made mention of timing. And so I can say that there are some barriers for timing. We do recognize that some patients will alter how long they will go because of the fact that the cost you made mention of is definitely a barrier for many of our patients. And so we encourage them to stay with the recommended dosing schedule. But some patients actually will let us know, I actually will make this go a little bit longer because of the cost.
That's interesting. And actually we were going to maybe talk about what are some of the common challenges or barriers to starting biologics. So I think you've already described one of them. Dr. Kraft, are there any other thoughts on the common challenges you see or barriers in your patients?
Absolutely. Well, I think it's more there's trepidation about how long do you, I get asked a lot, how long do I have to be on this medication? The rest of my life? What does that mean? So that's number one. And usually we go for like I said, 4 to 6 month trial to see how well it works. And then there are patients that have been on these for years. There's actually our data now suggesting you can go a little longer, or there's some that you can actually taper off and the patients do well. About maybe 20 to 30% of patients who've been very stable on biologics for a long period of time can come off and actually enter a period of what we might think about as remission, which is a word that I never thought I would hear in the asthma space. Mm-hmm. Now, that leaves a pretty large majority that have to go back, but at least some seem to have some demonstration of remission. So that's really exciting. So there's that piece. There's also the whole process of getting a biologic authorized through insurance. That can take several weeks. There can be large copays. So some of the biologics offer assistance programs. And what I've run into recently, and I have to say for a long time, there really wasn't a lot of issue around the finances because everything was covered pretty well in the U.S. I've noticed now that there's a little bit of a chink in that armor. I'm noticing copays a little higher. Insurances wanting me to go with one biologic versus the other with no regard to biomarkers, which is quite upsetting because I think we practice pretty good precision medicine in asthma as best we can. And to be told from a carrier that I have to go with a certain biologic that I don't think the patient really would benefit from is concerning. That's another issue. And also, another thing that can happen that can be a really good thing is sometimes patients feel good and they stop their underlying inhalers because they're feeling so good. Now, I call that a victory. However, when it's time to renew that biologic, the carriers may not, because they'll notice patients not taking their inhaled steroid anymore, or they've drastically reduced the frequency. And so while I consider that a victory from a clinical perspective, I'll have to ask the patient to restart their medicine and stay on it for a period of time in order to renew the biologic. And I find that obviously concerning. So we have work to do in that arena.
Mm-hmm. So that's, insurance, I guess, is a common challenge or barrier when it comes to biologics. And I think that was, the thought of transitioning someone on a biologic that maybe they're well maintained on, their asthma's well controlled, and the thought of transitioning is concerning. I guess if we wanted to know what your thoughts were on transitioning a patient. I guess in a perfect world where maybe you think that it's time, like one biologic might be more efficacious, or what are your thoughts on that?
Actually, I'm really happy to say there's been some great data lately on switching. And so really, when we do see partial responses to these biologics, I certainly have what I call my poster children, those patients who respond beautifully and everybody's happy. I wish the world were like that all the time. So we have some who had these partial responses, so they may get a little bit better in terms of reducing the frequency of exacerbations. Maybe they have some some small benefits to lung function, but overall not really getting where they need to be. They're still requiring prednisone, and they have a lot of symptoms. Quality of life isn't quite where they want it. So at that point, we might think about switching. And because these biologics each target a certain pathway, and in a perfect world, I'd love to use combinations to get more than one. They're not a steroid, so that's a really beneficial aspect. But there have been data sometimes going from one to another, changing the biologic that targets one pathway to another can have benefit. And so and there have been a couple of studies recently suggesting that maybe the switching doesn't happen as often. There were a couple of very large studies done in Europe, where in fact only about 10% were switched from one to another. And so I feel like there was the IZAR study I'll quote, which had about 2,000 patients, and about 200 of them only switched, 222 to be exact. And then there was the Chronicle study, which had over 2,000 patients, about 162 were the only ones that switched from one biologic to another. And so these were felt to be, that was a registry, the International Severe Asthma Registry and the U.S. Chronicle study were kind of real-world data. And so I'm concerned that isn't happening as much if patients really aren't responding, because the data suggests that oftentimes when you do, that there are some nice results in terms of reducing exacerbations, improving symptoms, and improving lung function. So I think it's important whenever patients do start biologics that they get monitored. They check in with their physician. I like to see patients usually about a month or so after they start their biologic, and then I may see them again at 4 months, and then I'll see them. And then if they're doing well, I may go another 3 or 4 months just to make sure that first 6 to 7 or 8 months, I see them quite a bit to be sure that they're responding.
So it sounds like you kind of mentioned that some of the studies, maybe switching isn't something that they do often, but it sounds like you've had some positive clinical scenarios where switching, you've had a benefit and you might encourage switching.
Absolutely. I think that we do see some partial responses. Not everyone responds 100%. And so I try to see patients, usually within a month of starting a new biologic, and then at least 1 or 2 more times in the first 6 to 8 months to make sure they're on track. Because if they're certainly having exacerbations on biologics, usually I wait till after they've been on 4 months. So anything after 4 months, I sort of attribute it to suggesting that biologic isn't happening, isn't working as well. And then, so I'll consider maybe a change. So I want patients to try them for at least 4 months. Or go a little longer if it's not really clear they're having a complete response. Sometimes I'll go 6 to 12 months and then make a decision. The data out there suggests that patients do well when we change biologics, because there may be more than one, there probably is more than one inflammatory pathway really raising its head in asthma, and we're only targeting the one with the biologic. And I'd say in a perfect world, I'd love to use combinations, but maybe someday. But for now, I'll have to switch from one to the other. And there are nice data suggesting a reduction in exacerbations, improvement in lung function, and I've seen it in my own practice.
Yes, that was one of the questions we wanted to ask you about the combination, but I think we also wanted to know from the patient perspective. So Dee, do you think that switching biologics, is there some trepidation there, or what are your thoughts on that?
Well, in regards to switching biologics or even going from one to the other, I think that patients really, if they understand the reasoning behind it, then they would be on board. That just kind of going back to barriers is what, we've seen is that we have kind of like 5 buckets for the patients. We have a group of patients who are have a great relationship with their healthcare provider. The staff works really well with the patients and make sure that they get the biologic, that all of the steps are very, very clear as to what they need to do. We have another group of patients that maybe they have a great relationship with their healthcare provider, but the process to get to that biologic is very muddled. And so they don't know that this is coming from a specialty pharmacy. They don't realize that there's going to be a phone call from a biologic coordinator. They may have been told that, but because of life in general, they don't answer the phone or they're at work. And so they miss some very important milestones that then impact the timing of them receiving that biologic. And so then there could be some frustration that is taking place. And so I find that, again, just that education, we talked about educating them about using the biologic, but we have to also educate our patients about what the process is going to look like and why it's important for them to follow that process, so that when the time comes for them to receive that biologic at home, that they're getting that, on time and within a timely manner. Again, transitioning biologics patients they want their asthma to be better. They have been living with this for a long time, and they are very frustrated when medications are not working. And so when we get to that point of using a biologic or switching from one to the other, it's magnificent that they can do that. And then being able to, again, understand the process. And I think Dr. Kraft also talked about cost. So just, if there is an assistance program for patients, is to make sure that they recognize what that's going to look like, because there's a lot of homework in regards to the assistance programs too that many of us may not be aware of. And so patients need to recognize that when they are enrolling in these, that there's homework for them to do. It's not just getting the assistance, paying for that. There's more homework for them to do afterwards.
Right. That's really good advice. So today I saw a patient who has very severe asthma, had stopped smoking and unfortunately started up again, had been on a biologic, had an exacerbation. So but he's been on this biologic a long time. So is it time to switch or really focus on the smoking cessation? And so we really had a long conversation about what it would take to quit smoking, but then we might consider switching to biologic after we see the effects of not smoking, because I'd always had this concern that this particular biologic is something that he didn't really qualify for as well per biomarkers. He was already on it when I saw him for the first time, and I thought another one might be more appropriate for him. And so it was an interesting discussion that we had. So we decided that we're going to focus. He really wants to quit smoking, so we're going to put all our efforts there. He'll keep up the other biologic and then come see me, and then we can decide, do we need to make that change? And then we'll go through the process to do that. But explaining that piece about getting the call from the coordinator, it's a specialty pharmacy, I do think that's really good advice, because there's so many pieces that happen outside the office for where the visit was that can really go well or not so well. So I think you're absolutely right on that.
Yeah, I think kind of seeing where your patients are at, right? So your patient wants to quit smoking. That's amazing, right? So you really want to encourage that, and then keep in mind the context of how you treat them with their biologics. And then I think, so we really wanted to ask you what your thoughts were a little bit more on combination biologics, if you ever do it, or have some strategies.
I do. As I mentioned, I love the concept of using combinations, and there actually are ways you can do it. So if your patient happens to have atopic dermatitis and severe asthma, there actually is a biologic that's for both. So you might want to start that one first. Then, and then depending on if they completely respond, say they don't completely respond, you have the option of starting another biologic for the asthma. So I have done that. The more common scenario, because what's interesting is I don't tend to see as much atopic dermatitis with severe asthma. It's sort of interesting because I see an adult population, but chronic rhinosinusitis and nasal polyps, plenty of that. And so that tends to really present itself oftentimes 30s and 40s. And often in these days, we have biologics that target polyps. And again, you get some benefit from the asthma. But if the asthma isn't completely controlled, then you have the option of thinking of a second biologic for the asthma. So I have come up with those scenarios, and that's the very legitimate, not trying to do anything crazy. And so it can be a really nice way of using combinations. TD, I don't know what you think, if patients give you feedback about that.
Absolutely. We've had a number of patients who have asthma and have eczema, and patients that have been in studies specifically for their eczema who've been placed on a biologic, and then lo and behold, they said, oh my gosh, my asthma is improved. Well, you get a 2-for-1 in this.
Okay, you do.
Well, helping them understand that it can be beneficial for their breathing as well as for their skin. And again, I just think that it really takes a lot of education. We haven't really touched on studies, but we do encourage our patients that if that could be a health option or healthcare option for them in the event that they aren't able to afford the co-pays or other arrangements for paying for their medication, is that they could have an opportunity to participate in a study that may benefit them to receive those biologics too.
Absolutely. I'm glad you brought that up, because we do trials, and I usually have a research coordinator with me in clinic thinking about those patients who may want to do these trials. Sometimes they're biologic focused, sometimes they're not. But I think my patients are pretty used to it now. They're used to being offered studies And, usually they're quite willing, depending on the trial and where they are with their asthma, and if they feel like they want to try something. And I really appreciate that, because how are we going to learn, about new approaches, new interventions if we don't have those willing participants? So I'm really grateful for that.
Any other thoughts on where we're headed into the future?
Yeah, there are some really interesting things happening down the road. We have, in addition to this long-acting IL-5 inhibitor, depemokimab, that's also that was just published as a phase 3, so that's moving along. There's an interesting phase 3 study going on where looking at a TSLP inhibitor and an IL-13 inhibitor called lunsekimig, and it's actually phase 2, I should say. And what that is it's an interesting nanobody backbone. This is an injectable medicine where you can put different inhibitors onto the same drug, if you will. So this one has 2 biologics on it. So TSLP is a mediator produced by those epithelial cells that line the lung, and they're sort of the first line of defense, if you will. And so it's suppressing TSLP, which can create a lot of this type 2 inflammation, and also non-type 2 for that matter. And then it also inhibits IL-13, which is a type 2 cytokine. So you get 2 for 1 in that one. There's also, speaking of TSLP, there's an inhaled TSLP inhibitor that's now in studies as well. So that's looking very interesting. And so we'll see where that takes us. There's also masitinib, which is a tyrosine kinase inhibitor affecting some of the mast cell functions. A mast cell is one of these inflammatory cells in the lung and the sinuses that can release a lot of mediators, especially like leukotrienes and other preformed cytokines that can cause this airway inflammation that results in shortness of breath, wheeze, and cough. And then interleukin 33, which is a cytokine that's also produced by that airway epithelium. It was looked at asthma for a while, and then it moved to COPD. So there's some interesting trials in the phase 3 space looking at IL-33. And it looks like it's coming back to asthma. So we'll see what that does. So I think I can go on and on. The pipeline is quite rich, and so I'm excited about the future for sure.
Yeah, I'm really excited about all the asthma treatments, but then also the COPD. So I see a lot of patients with COPD, so I'm super excited.
Oh, definitely. It's nice to have COPD. That's really a big unmet need as well. You bet.
Yes, there was a while where it just felt like there wasn't a lot coming down the pipeline, so we're so excited too.
Yeah.
It sounds like Dee, so patients are pretty excited about the future of asthma. What are your thoughts when they kind of thinking about the future of biologics?
So I think patients are excited about the future, but we have to remember, social determinants of health do impact the access to these medications. And then we've talked a little bit about research. So patients know what they are provided, or if they go and do a Dr. Google search. And Dr. Google is not the answer. So we want to be and wants to be the resource of all, so that patients, when they're looking for information, and many of our patients are going out on TikTok, right? Or they're going out on other types of social media to find information about the future of asthma. So Allergy Asthma Network's actually created a TikTok channel to be able to be a well-known resource that is credible, and having credible influencers like Dr. Kraft or some other physicians and even patients who are using the science to share their information. We've also utilized podcasts to get information out about studies and about the future of asthma, severe asthma specifically, and even just recently we had a biologic podcast specific for patients. So we had a patient being interviewed with a healthcare provider. So I think patients are very excited, but just remembering that, when we're thinking about where medications are going, is making sure that we have access to all, so that those social determinants of health actually don't impact who gets and who doesn't receive that medication.
Yeah, that's a great point. I mean, there's all this exciting medications out there, but if we can't get them to our patients, or they're not able, we talked a lot about barriers, insurance, all these issues. So that is the real world, unfortunately, that we live in. So, that was such an amazing talk, and we just want to thank Dr. Kraft and Dee again for learning so much about biologics today on the ATS Breathe Easy podcast. So we just want to thank them again. Thank you.
Thank you for having us. Great to be here. Really appreciate it.
Thank you for inviting me.
Thank you for joining us today. To learn more, visit our website at thoracic.org. Find more ATS Breathe Easy podcasts on Transistor, YouTube, Apple Podcasts, and Spotify. Don't forget to like, comment, and subscribe so you never miss a show.